Thanks everyone for coming today. As the title suggests, we're really here today to talk about supporting students. And I don't have a lot of slides, and though there's certainly a lot I can say about supporting students, and my intention is to go through the prepared material and then have plenty of time for discussion. But I'm also totally fine with people interrupting as I go and asking questions. In the interest of sort of giving the audience what they need, are there things in particular people are expecting to hear or want to make sure that I talk about today? I'm going to make you be interactive right from the start.
Students distress during like moments of crisis, and non-traditional moments like 2 a.m., 3 a.m.,
Okay.
4 a.m., all those AMs, all the AMs. And so if there's any way to also talk about like how this scenario and the setting might impact that distress as well. That might be a whole other training, but if there's like
no,
any
that's
way to
fine.
tie that in.
Repeat the question.
So
Sure.
if the students are witnessing.
Yeah.
That's traumatic, really distressing events as well. Like,
I would say like us, like for those that are witnessing, like a roommate going through something or, a suite mate or anyone or someone down the hall. I would that's what I was also thinking, like, how do we support the students that are not directly in an incident, but are. Yeah.
Great. So the idea, the question suggestion is about supporting students who are not necessarily experiencing a mental health crisis themselves, but maybe adjacent to or witnessing or roommate or some other way connected or present. Yes.
Yeah, seen a trend, and you won't be surprised. Students helping students. Yes, our students are just wonderful. They're so giving and helpful to the other student with their mental health issues, but it's impacting that student's own mental health, who might have some mental health issues, and escalating there. And then it's creating these very unhealthy relationships where this student may be texting all the time, suicide ideation, and the other students come running. And it's very disruptive to, sometimes to a whole room or a whole floor even, I think.
Yeah. So we're just talking there about the disruption to a peer who's supporting a peer in crisis. Absolutely. I probably should have started even before asking for what you want to hear, just to identify the audience better. And again, not knowing how big the group would be, I didn't know if I would ask that, but there's few enough, I think we can. So why don't we just start in the front? So I've met 3 of you in the front row, and
I do federal and state compliance. So I'm also Title IX in the list goes on.
okay, so someone overseeing compliance,
Yes,
behavioral health. Did you say contracting or
it's a consultant team.
consultant team? Sorry.
So it's a bit. The colleges all have behavioral intervention teams.
Got it.
Yeah.
So some of these words, one of the things we're happy to talk about is what the words mean. So behavioral health intervention team in a hospital generally refers to a immediate response team to do restraints or people to do behavior plans for folks with autism. I suspect that's not exactly what you're talking
That's
about.
what
Okay.
adopt the national language of intervention team.
Okay, good. So again, not exactly what's happening here, but still informed with the same practices. Great.
Oh, yes.
Great. And
Good morning. Yep, Sharon Fricker. I've been in the same room a couple of times. I'm over at Hazen as well, and I'm the associate director of the health center side. So work very collaboratively with the counseling center side. I'm also on SBCT. So
excellent.
very interested to hear what you have to say and understand better this, how we can work all together to deal and provide services for these students.
Great. And actually, I think it's worth commenting for a moment. Thank you for being here. It's not intuitive to everyone that the general health center or general medical providers would be part of the discussion when we talk about mental health support. Unless you're working in that setting, in which case you know that that's probably somewhere in the neighborhood in primary care settings for 18 to 25-year-olds, about 30% of the work that people do. And if you excluded issues around sexual activity, contraception related tasks, because in some areas in primary care, people go to like a Planned Parenthood or center like that, then it becomes about 70%. So I don't know if it maps on exactly like that in our health center here, but general medical care is an important part of how we think about mental health support. Start in the back. Yeah.
Hi, my name is Aaron Enriquez. My pronouns are he and his, and I am a resident director here on campus. I work in Mortimer Hall. I'm one of the newer members to the SUNY Brockport community. I've been working here for a little bit over months. I previously came from SUNY Geneseo. I'm not new to supporting students in crisis, but I am new to SUNY Brockport. I'm very curious to see policies and procedures here at SUNY Brockport and how we make the effort to support our students in distress.
Excellent. Thank you.
Hunter Lincoln, the resident director here. I went to Brockport all 4 years of my undergrad, and then I kind of took a hiatus for a month, but I'm back.
For a whole month.
I tried to run. But I worked as an RA for all 3 years while I was in my undergrad and loved it, loved residential life and being a resource for students on campus.
Great.
Hi, my name is Adrian Vega Bautista. I am a residence director here on campus as well. I'm the residence hall director for Thompson Hall.
Okay.
Just recently started as well. I think I'm almost a month into the role as well. I don't know what else. I've been an RD for a couple of years already too, and learning different ways to help students with stress and different techniques as well. So
Excellent. Thank you.
Hi, my name is Michaela Nolan. I'm also a resident director. I'm also going to preface saying I am on duty, so if my phone rings, I do have to step out and take that call. And if I have to disappear, well. I oversee McQueen Hall as well as Perry Hall for a few short time, hopefully. This is my 3rd year as an RD, 2nd year here at Brockport. Yeah.
Okay.
I'm Kara Furlette. I'm the assistant director for Living Learning Communities and Academic Initiatives in Res Life. But part of my job is supervising half of BRDs, and we're also on call leadership team. So I think as like leadership team on call, like learning how we can support our RDs who are handling the crisis on ground, and like they're in the crisis, so helping them like we have a calmer eye to be like reminders of how to help the student. So.
Great.
And I am Amber Rice. I'm our assistant director of residential curriculum. I'm supervising other half of the RDs. And everything that Kara said, but also one of the main parts of my job is training and developing our staff. And so really also, I'm trying to figure out how do we also integrate this earlier on to help us be more proactive instead of reactive with regards to training and support. Help build that confidence as folks are. I'm also worried about the icon.
Excellent. We have our director of the counseling center. I thought I saw someone pulling on the door there, but guess not. They're open, right? No one should be locked out. And our director of Hazen. And Matt, could you remind me your title?
Yeah, I'm Matt Hall. He, they. I'm the associate director of health promotion and prevention education.
Okay, thank you, Matt. And we have someone on Teams.
I'm here,
George, I
I'm
don't know if you
Jennifer
wanna
Bianco,
unmute
I'm
to introduce
the
yourself.
administrative assistant for the health center.
I'm
Well,
George
I don't-
Piccolo. I'm
okay.
the Gordon RD.
Do you want to do that again?
What's that?
Jen and George. Do you want to introduce yourself again?
I'm Jennifer Bianco, I'm the administrative assistant here at the Hazen Health Center.
Oh, great.
I'm George Piccolo. I'm the RD of Gordon.
Thank you.
Excellent, thank you. I'm gonna let Matt do the muting again so he can end the echo. And so really, we have a strong representation of residency directors and the sort of res life perspective. I want to respond to one of the things that was said already. And actually, I'll do it as part of an introduction of myself. You can see all my titles on the screen, or many of them. I've been in academics for a long time. And so, if you stay in the same place long enough, you end up with like 6 titles. But the most important part of a professional introduction would be that I'm a child and adolescent psychiatrist, which is a subspecialty of general psychiatry. And I've been working in the community here now for 25 years. I'm the psychiatrist in chief at Golisano Children's Hospital, but that means I oversee all of our mental health services. And something that may or may not be intuitive to you in your current day-to-day lives is that as in academic psychiatry, from age 18 to 25, the term that's used is transitional age youth, and sort of expertise around transitional age youth and college mental health is really part of child and adolescent psychiatry. You don't need to remember any of that, except if you're interested, there's resources about college mental health and transition into adulthood in the American Academy of Child and Adolescent Psychiatry website and with that professional society. I've worked in and around college mental health now myself for about 12 years. And this is a lot of that has been here at Brockport as a consulting psychiatrist to the Hazen Center. And one of the things that's cool to give this talk right now is some of the things I'm going to talk about how colleges can have responded to the mental health crisis, or what some have referred to as the swelling tide of mental health needs among students. I've seen some of the changes that have happened here over recent years, and I can certainly speak about them. I also want to say one of the comments made already was about I think the term used was unusual times or non-typical times for presentations. So a lot of my career has been working in the hospital. And so any plan around crisis management for mental health needs, in particular around violence or suicide, if it's not a plan for Friday or Saturday night at 2 a.m, then it's not a good plan. So evenings, overnights, weekends at 2 a.m is actually exactly the time that many of these incidents happen. And so I don't see that as off or atypical hours. And in fact, part of the, to use a medical metaphor, part of the whiff test of whether something someone proposes to you is valid or not is it applicable at 2 a.m on Saturday? And if it's not, then it may not be helpful. I want to talk a little bit about data and about national trends. Now, I can talk in more detail and answer more questions about numbers, though I think the most important part is to get into sort of details of what you can do and what we can do as a group. Some of the most important things that I think stand out from this, and I want to thank Darlene Smith who prepared this and some of the other slides I'm going to use today, that if you ask students about mental health distress or psychological distress, about 3/4 respond that they're having moderate to severe distress, and that's in spring of this year in 2023. This is a lot. This is the highest number that has come from a survey like this, and there's been an increase after the pandemic. But if you look at what the trends are, the trends actually started in 2008, 2009. So this isn't a new phenomenon, though the numbers every year seem a little worse. Some of the other concerning things, the more than 10%, about 1 in 10, and if you think about all the students report intentionally harming themselves, cutting, burning, other forms of self-harm in the last 12 months. A third report having a formal diagnosis of anxiety or an anxiety condition, a quarter being diagnosed with depression, and almost a third having suicidal ideation in the past year. The identifying the number of actual suicide attempts is a little trickier because most of the data we have about large populations comes in from surveys. And as someone who does a little bit of suicide research and works at an academic medical center, I know that it's actually challenging in a survey to know if someone, when they're looking back and they say they had a suicide attempt, did they actually do something that they really believed would end their life? Even if they really believed it would it really have ended their life? And that can go in either direction. Sometimes people do things that they think are not that dangerous that are in fact quite life-threatening, and vice versa. But as a marker of level of distress, the fact that self-reporting 2 in 100 college students says that they made a suicide attempt, that's kind of alarming. And it's consistent with changes we see in youth populations and in adults through the country outside of academic centers. Suicide is the second leading cause of death for youth from age 10 to adults age 35 right now. And if you exclude, and then, sorry, it's only second if you include all accidents, adding them all up together, every type of accident, that would be number one, and suicide would be number two. In terms of the raw numbers, that represents a doubling of suicide deaths every year from 10 to 14-year-olds, but fortunately, not that many 10 to 14-year-olds die at all. Every case is a tragedy. The greatest number of increases are actually in adolescent girls, and particularly in adolescent girls of color, we see a tremendous increase in rates of suicide deaths. Now, going back to the college counseling center lens, from when the trend started, it's true to say, based on data that that presumed a similar model of how the counseling centers were organized, a 40% increase in the number of students seeking services from 2009 to 2015. Now, if you want to have an academic approach to this, I can talk more about that. I can answer questions. Is 2008, 2009 as sort of the kickoff of the youth mental health crisis? And again, as I talk about that, I include youth up through mid-20s. What does that correlate with? Well, iPhones started being in everyone's pockets in 2007 and 2008. We see these increase in trends, again, particularly of 10 to 14-year-olds starting in 2010. This was really a time when, if we look at this as a mass population level phenomenon, this time period is significant. If we look at why did I pick on 2009 to 2015 for college counseling centers? Well, it's also during that time that a lot of places started doing things dramatically different. And so when I say 40% increase in students presenting, I have a general level of confidence that the counseling centers in this period of time were communicating to their student bodies that they can do some sort of initial education assessment and then a time-limited individual therapy for everyone who asks for it. Now, there's always been some variation depending on where you are in the country and what the school sets as their mission, but that's pretty much the traditional model of college counseling centers. In response to this swelling tide, this dramatic increase, places started doing things different. Some places really leaned into the idea of walk-in crisis assessments so that, if someone had a real right now problem, the counseling center would prioritize managing that. That's something that's happened here at Hazen, at Brockport. Some places have sort of doubled down on the idea that, well, if we just try to do something for everyone, then no one's going to get good enough care. And so we're going to be, in fact, more limited. And this idea of providing short-term individual psychotherapy being a precious commodity that we can deliver this many widgets per year, we're only going to deliver that. And there'll be a screening process to say whether you're eligible or not. And if not, then you don't get any care. Now, I've presented that in a somewhat cynical, exaggerated way, and that would be the other extreme from leaning into the crisis appointments. And what most places have done somewhere in between. But the net result is counting numbers of how many people presented for care isn't really generalizable across counseling centers anymore. In fact, information from 2000 since the pandemic and shortly before, saying, oh, we saw this many students per year doesn't really mean much. And I say that, I don't know if I'm gonna like offend anyone's request for budgets or what people think is an important metric. What I mean by that is, as an academic trying to sort out what are we actually doing to provide mental health support for a student population or for the individual students. If I don't know whether providing care to one student means that you did a triage and decided whether or not to go to the emergency room, or you did psychotherapy every week for a year, then if I don't know which it is or somewhere in between, then just knowing the number doesn't really help. So that's the state we're in, though. We have different places doing different things. It's harder to generalize. And the resounding conclusion, though, has been the consensus that this idea of everyone having access to individual counseling is not possible in any school model right now for every student to have access to individual psychotherapy. And the models of psychotherapy that have been offered traditionally may not be a great fit for what students' problems are anyway. And this is a slide looking at the top reasons people present to the counseling center here in Brockport. And as you can see, the biggest number is anxiety-related conditions, followed by trauma-related, then depression, and then what we call adjustment reactions, and then eating disorders. This is the top reasons people present. But even within that, there's quite a wide variety of what that means in terms of how people present and what they might benefit from. Now, I don't know if anyone has any reactions to that, but as a psychiatrist, I look at that and I don't see bipolar disorder. I don't see schizophrenia. I don't see borderline personality disorder. And given the overwhelming numbers, as we think about the scope of what we should do, we probably should not be the care providers for people with those conditions. Now that's a little, I don't know how that sounds to your ears. I can tell you that there was a time, in fact, the first 2 years that I worked here, that saying that out loud was quite received quite negatively, was quite a polarizing thing to say. But the reality is that if you try to mobilize a counseling center, the way the staff is made up, the way the hours are, the academic schedule, to treat people with what we call serious and persistent mental illness, it's a mismatch where much of your resources goes to help 3, 4, or 5 students that could have served appropriately 40, 80 students. That sounds ridiculous, those numbers, right? But that's actually what we see happen. So figuring out the scope of what you can provide, not only in quantity, but what your staff, what your structure and organization is actually equipped to do is really, really important. And again, there's not one standard model, one standard best practice, although the biggest limitation for there not being one standard best practice is this. Oh, sorry, if you go back to the preview, I went backwards. Is that there's not been a corresponding increase in staffing or funding comparative to the increasing need. I would suggest, and I think I'm right, that if we had a increase in budgets and staff relative to the increase for demand, I'd be able to stand in front of you in 2023 and say this is a best practice model. However, by definition, no one has the resources that anyone who's thought about this seriously would need in order to develop a best practice model. So that sounds bleak, but it doesn't have to be bleak. All it means is you have to be realistic. As schools, we need to, and I say we, I'm a consultant here in psychiatry. I work in the counseling center, but not that much. But I also work at the University of Rochester. I also consult with other colleges. So when I say we, I don't just mean SUNY Brockport. We need to stop telling parents and students, though, that, oh, we have a counseling center. Whatever problem you've ever had, we can meet all your needs. That's actually a lie, and it's not cool. I've been a parent. I have 4 kids. Almost all have gone through college now, and I've had people tell me that as we, go on tours. And I laugh sometimes. I ask questions other times. It doesn't help because the person saying it doesn't really know what the counseling center actually can provide. But we really need to be honest and realistic about what the scope is for any counseling center. And we need to recognize that you're not going to be able to do it alone. The idea that, oh, there's a mental health problem, the counseling center will take care of everything. That's not possible. I mean, we could print cards for Santa Claus and it would be just as realistic to give those out. It's not possible. So what do? I said it's not hopeless. There's a broader world, right? We define the scope for what the counseling center can do. We define scope for what the medical center component can do, integrate them as best as possible, and collaborate with the outside world to connect people with resources for treatment that may not be available and not be appropriate to try to create in the college campus setting. You also need to look realistically at more beyond treatment. And I would suggest the first step in doing this well is actually taking a step back and looking at how we talk about mental health problems. And now we're going to start to get into the part that I think is most relevant to the questions and comments at the beginning of not only how to help someone who's in crisis in front of you, but how to think about things and help the people adjacent to the crisis. And we'll go into more detail and we'll have time to discuss specific situations if people would like. But again, I want to start with this taking a step back. I mentioned before that words are important and defining the words are important. I think that we do ourselves, students, each other a disservice when we refer to everything as mental health without further qualifying. Again, it's this, similar ideas to what I said before about scope, about sort of distorting, unintentionally distorting what you can offer, what the message should be for someone. And so taking this step back, I think it's really important to recognize that there's a difference between anxiety, sadness of everyday life that we all should experience. If we don't, that's actually a different problem. And even significant distress in a time of crisis or adversity. And that both of those are different from a diagnosable mental health condition that can be conceptualized similar to a medical condition and requires medicalized treatment. In this case, when I say medicalized, I don't mean medicine per se, although it may include medicine. I mean the medical model, which I don't know if anyone's presented this to any of you guys before, if this will sound familiar, but the medical model that a couple hundred years ago, there was competing models. The medical model today, the allopathic medical model, which won the philosophical fights with allopathy with the invention of antibiotics, is that disease is separate from the self. We kill it, and its absence is how we define health. I don't know if that's a good way to think about anxiety or sadness after, something bad happens to you. Right? I think that if we don't try to be a little more sophisticated, at least, I think we can unintentionally set people up for, if nothing, ineffective or disappointing experiences and possibly even do harm. So if you've been looking at the slide while I've had it up, that's great. I'm going to go over it in more detail in a second, but now how should I do that? I have a video I want to play, and I don't know how this is going to go with Teams. So let's go back to the previous slide, to the pyramid. So I realize for those in the room, the sound may not have been that loud, but did you get the gist of it? And so the idea is, and I think this is really important, and it is, if not the first step, a step in answering how do we support not only the person in crisis in front of us, but people around them. I think that in many settings, we have unintentionally set up the idea that any distress that warrants support or acknowledgement has to be referred to as a disorder or as a crisis. I don't think anyone would do that on purpose, just to be clear. But I do think that's a lot of what happens. People saying that, oh, I'm having, insert your word, your phrase. I'm having a panic episode. Well, panic episode is a very specific thing it includes catastrophic thoughts. It includes somatic symptoms, and oftentimes people are using the term for any spike in their emotional distress, which is, I don't want to pick on people for how they use the word, but it ends up not being helpful. You can, in terms of knowing what's really going on, if any word means everything. So the idea of separating out, I'm experiencing more distress right now because of what's happening in the moment, versus I'm someone who's sensitive to certain things, and those things are happening now or they're at risk of happening. Those are very different things. So I think developing a language where we can talk about sort of everyday up and down feelings, which are absolutely normal and not to be avoided but embraced, and everyday stresses. If we didn't have distress, if we didn't have stress, no one would study for their exams. In fact, no one would learn to feed themselves or walk if we didn't have stress. So the idea of having a stress-free environment is essentially, the idea of saying you're done living, let's go to a nursing home. I don't think anyone wants that for students, for their peers. That would be silly. But I think that, again, it's one of these like unintended consequences of meaning to reduce toxic stress or intolerable stress. The idea of acknowledging the severity of someone's distress and that it warrants attention and caring, and at the same time doesn't mean that it's a disorder or a condition that needs to have medical care, is also really important. Questions about what I've said so far about this idea? I think this is actually I think the pyramid is a very useful thing. You could make posters and have them up in the residence halls. We could, use this material, which is, it is developed by, you can see the icon on the bottom, mental health literacy group, or the website is mentalhealthliteracy.org. This was actually if you could hear the video, you may have noticed some funny pronunciations, like pronouncing out as oot. This is a Canadian group that put this together. It was actually funded from an initiative to support First Peoples in Alberta, Canada. But it is, they've developed materials which can be used in any setting, which I think are very helpful. So with this in mind, with trying to take a sophisticated approach to supporting people where they're at, I want to talk a little bit more. I'm going to go ahead 2 slides now, about what's happened here, what resources may be available, and then talk as a group about how to problem solve for things that are the real most common problems in front of you now. The defining scope, I've talked about this on principle, and that's something that we've certainly done here at Hazen. And hopefully this is what I'm about to say next is stuff you already know. Anyone can go for a walk-in appointment every weekday here at the counseling center and get an assessment. We've also worked at the other end, if you will, that it may well be that at the end of the assessment, the recommendation is that your needs can't really be fully met at Hazen, and we need to collaborate with an outside mental health provider that's better suited to meet those needs. Education, like what we're doing right now, but elevating people's awareness and people's sophistication about mental health needs. And I want to mention some of the outcomes and then recommendations from the Steve Fund, which is part of a national initiative for colleges that that Brockport participated in the 21 to 22 year, analyzing the data and making recommendations for initiatives. This includes, again, some more education material. It includes a campus wellness steering committee. It includes a number of specific targeted, if you will, at certain populations or subpopulations, activities and opportunities or supports, including this material about how to connect a student with the counseling center. Is this something people have seen before? Beautiful. Excellent. Excellent. And so that has some more details about how to think about how to utilize the services that are here, the hours, the parameters. Which is the next slide. And so I just, for people who aren't in the room, and just to emphasize for those who are, that's how enthusiastic the leadership at Hazen is about helping support students. That was our Hazen Health Center director commenting on the importance of recognizing after-hour resources, because as we talked about and I emphasized a little bit earlier, the regular business hours for employees is not necessarily the regular hours for a crisis. So there are some things that are available, still scheduled, still not 2 a.m, but 4:30 to 9 p.m. is might be a better time fit for some folks. This pre-practicum helping clinic, why is it called the pre-practicum? This is about trainees providing a lot of the support. And if we think about the mental health pyramid, the idea, so this is students can meet with a counselor, pardon me, or a counselor in training to talk about issues that are bothering them or to help sort out, how to think about the distress that they're having. So if we compare that to the mental health pyramid, that might be normal everyday stress. It might be mental distress. It might even be sort of the first step of sorting out a mental health problem. It would not be treatment for an identified disorder. But it still might be a fine place to check in and figure out, where do I get such treatment? I also want to mention QPR training. So this is something that's being rolled out. The SUNY Brockport has an account with the QPR Institute to do trainings. Now, has anyone heard of QPR training? Oh, a few of you have. Good. So this QPR stands for Question, Persuade, and Refer. The QPR Institute has a number of trainings. The gatekeeper training is the one that is available for free and recommended for really anyone who would want to do it. It can be any student, any employee, and certainly folks who are in Res Life, we recommend it. If you look at their website, if you look at the promotional materials, the Institute compares QPR to CPR, and it's a metaphor that I think is useful in terms of community dissemination. I worry that it's actually limiting, as the idea that this was developed as a suicide reduction tool or approach. If you do the training, you'll see it's generalizable beyond suicide crisis. And so it's not, CPR is actually one part of what you learn in the training is, you're likely going to break someone's ribs if you do this right. So don't do it unless someone really doesn't have a pulse. The QPR is much more benign. You can actually do that. It can be applied to all sorts of distress and situations. It doesn't have to be limited for the worst case crisis. But again, in terms of dissemination, it can be used for the general public. You don't have to be a therapist to learn how to do this. You don't have to go to an all-day training. The training is online. It takes less than an hour. And it can be a structure for engaging with folks around possible mental health crises. And the information on the slide here about how to sign up for that. I think the only real thing you need to remember, you could Google and get oriented toward the right website and everything, is that SUNY is the organizational code to get the training for free, so you don't have to pay whatever they charge if you just log into or just click on the site. I think it's $20 or $25 or something like that. But you don't have to pay that if you use the code. I want to say one more thing in terms of sort of different ways of thinking about something, and that's about building resiliency. And I think that this is another area that's relevant for helping students who may not be the center of the mental health crisis, but may be at risk, may be experiencing secondary or vicarious trauma from what they're witnessing. And that's the idea of building resiliency. So, I'm a doctor. I trained in medical school. I'm immersed in this allopathic model of fighting death, disease, and pestilence. But, really the goal at a population level is to build resiliency. It's not to eliminate all stress or distress, because stress and distress is going to keep happening. It's to build resiliency to face it. And one of the things that has been shown consistently and powerfully, and most of the data, to be fair, is with high schoolers, but I believe it's generalizable, is that identifying, if you spontaneously ask someone, sort of catching them in the hall or in an organized survey, if they matter to their community or if they have a role in their community. So people who say yes to that without knowing anything more about them actually have a less significant negative impact from some of the things we think of as the most significant life adversities, like death of a parent, incarceration of a parent, having been a victim of abuse or neglect. The mental health effects, the negative mental health effects, are modulated and lessened when someone says that they matter to their community. I think we're in a neat position here, particularly looking at it from a res life lens, to help everyone be able to say, I'm part of a community and I matter to my community. I think that's the best thing we can do to improve resiliency. I want to throw out a couple other resources that haven't come up that aren't specific to the campus. One is the U of R's Behavioral Health Crisis Line. Now, I mentioned that one. This is sort of a niche. You can call them for any reason, any crisis, but the reason to use that crisis line as opposed to 211 or the national 988 hotline is it's staffed by a licensed therapist. So if you find you have someone who's been to the emergency room and doesn't want to go, they're a little more sophisticated in their and experienced, maybe even a little soured to getting formal mental health help. Most hotlines are staffed by someone who's trained with scripts and can handle most questions, but not necessarily a lot of nuance. When you start talking about suicide and suicide risk, it ends up always being go to the emergency room. This hotline is staffed by licensed therapists who can help sort of think through in a more sophisticated way. Do you need to go to the emergency room now? Can we make an appointment for mobile crisis to come see you tomorrow? A little more nuanced approach. But barring that and not remembering that or needing to, 988 is a national hotline, always available. You can also text 741-741, text home to 741-741, and you'll be connected anywhere in the United States with a suicide hotline professional. Michelle.
Yes, just concerned about safety, and then university police will determine to call the fit team or not. So I don't know if that makes sense, like that there's also other options if a student is not necessarily in danger, harming themselves or harming anybody else, you're just really in distress. I think these are some great resources to consider, just have them call and talk to somebody.
Absolutely. Right?
Oh, yeah, they are. They're fantastic. They do a great job, but they don't always need that level of intervention.
Excellent. That's the end of the formal material I have to present. I hope this has been helpful, and I know we're pushing up against the end of our time, but if people have questions, I'd be happy. Yeah, so the question is about how to support a roommate or someone. I mean, we heard the story about what I would call sort of distorted friend groups or help groups that are trying, find themselves like on call for someone in distress. I'll try to answer both. And essentially the theme I would start with is to normalize and empower. So the normalizing part is, again, you could even use the mental health pyramid to sort of frame check about, what types of distress are normal everyday distress and what might really be unusual or really be too much for you as a roommate to be put in a position to manage. And whatever the answer is to that about where the boundary is, when's the too much, then to empower to say, yeah, your obligation as a roommate is to be polite and, have enough of a polite encounter that you can go to sleep at night and not have your sleep disturbed. And that's it. You're done. That's the empower part. I said that a little bit sarcastically or glibly. I know it's much more complicated than that, but that's also the advice I would give to this friend group that feels like they're on call to someone who, texts someone and says they're in a suicide crisis. I mean, that's actually cruel. Now, I don't know if the person texting that they're having suicidality is deliberately being mean, but as someone who's had the honor and the challenge of literally at this point in my life meeting with more than a dozen children who have told me that they received a message or saw a message hours later, if you don't talk to me within the next whatever period of time, I'm going to kill myself. And then the person did. It's really a cruel, hurtful action. It's not someone bleeding at the side of the road that you're going to be a good Samaritan and help. And so helping sort that out, the person may not be being cruel on purpose, right? Just like the person with intellectual disability who's hurting people may not be being mean or hurtful on purpose, but you still have to, be realistic about what the boundaries of your interactions can be with those folks. And as people supporting those people, help empower them to say, well, of course you're going to be polite. Of course you're going to be understanding. Of course we, want to recognize they're not being cruel or mean on purpose. And these are the limits of what's appropriate to expect you to do. Yeah, I mean, it's not only okay. I think there's an imperative to do it. You don't want to be stuck in a situation where you're worrying alone or worrying outside of your own capacity about someone's safety. That's not fair. It's not fair to you, and it's not fair to them. Oh, sorry.
Yeah.
Hmm. Yep. Well, it is. I like that but to some extent it's culture building or culture change. I like that you brought up the RA training. This is always easier to do in a prospective way than when you have easier than having the actual problem situation you're dealing with. So I love the idea of building it from the beginning. I don't know if we have a schedule yet for the third session of these. I mean, oh yeah, we could certainly. Oh, you get because the space is planned for something else. Apologies for that. Thank you for your patience, Matt. But we can talk more about it. I'd even be open to doing like scenarios. Like today I presented slides and we're talking, but we could just do 3 scenarios. Great. Cool. Sounds good. All right, everybody. Thank you. Thank you for your attention.